Okay, here we go. Part two of assessment and diagnosis for module three. Have my ice pack and my bandage going on. So working on sitting down for long periods of time with my injuries. And thanks for your patience on my uploading the recordings this week. So we're going to talk about a topic that is, I think, maybe less exciting for some people, but is really crucial in terms of understanding really how we use assessment instruments. And what I'm talking about here really is both different types of diagnostic interviews that are structured or semi-structured, and also the questionnaires that we use that have sets of question on them that we think are reflecting some underlying condition that people maybe have that we're trying to measure. So psychometric properties of assessment instruments. We'll talk briefly about standardization, reliability, validity, and then some cultural considerations. So let's move into standardization. And when I say that this is of less interest to some people because there's math involved, there's statistics involved, and for some people their eyes glaze over when they start to hear about things like the standard deviation. For me, I find it really interesting because it's, I guess I do like math and I like these types of puzzles, but what standardization is getting at when we're talking about psychometric properties is a couple of the things that we've started to already get at, with the idea of making normative comparisons and then the idea of self-referent comparisons. So for normative comparisons, we're really talking about nomothetic data. We're talking about nomothetic understanding of where someone is. And what I mean by that is that we're comparing that individual to the rest of a sample or to the rest of a population in terms of what their score means. So the chapter kind of talks about the idea of the normal curve. You have this figure 3.3 here that lays out that when we're talking about at least some types of psychological issues, that we might expect there to be some normal variation around an average, a population average. So there's a mean level, and then people are going to be either higher or lower on that given trait. To me, some issues like depression and anxiety, maybe that is, kind of close to normal curve. I think it's a little bit easier to understand when we think about things like personality traits. So when we think about something like being extroverted versus introverted, we can think about extroverted maybe being at this end of the normal curve, and maybe introverted maybe being at this end of the curve. Maybe, most people kind of fall somewhere right around the middle of that. They are not super extroverted, but they're not super introverted. And then there are people who are more or less extroverted, kind of around that mean. So we have some normal variation. So personality traits do kind of follow this normal curve pretty well from what we know. For certain types of psychological disorders, it's not as clear as this. It's not fitting as much of a normal curve. So the curve is more kind of centered, with the more people being closer to the low end, meaning that for types of problems like schizophrenia, like psychotic symptoms, for substance use problems, that those tend to be more people have very little or no problems, and some people have a little bit, and then very few people have a lot of symptoms or a lot of problems in that particular area. So it's not as kind of nice as this bell-shaped curve, but it's a little bit more kind of going up here, and then a longer, sorry about that, longer tail kind of over here. So the normal curve applies in some situations, it doesn't apply in other situations. But the same idea does apply is for nomothetic comparisons, is that we are comparing to the mean. So for different types of problems, we might have cutoff scores that we've developed. Again, we've talked about that for the PHQ-2 and the GAD-7. We might have severity bands, and again, we saw that for the GAD-7, where they had mild, moderate, and up to severe anxiety. For measures that are really well developed, they've gone through a lot of research and there's big enough samples where we can start to get something closer to a normal curve. There are standard scores or standardized scores or percentiles that we can sort of assign people based on how they answer questionnaires or how they do on different tests. So this standard scores or percentiles are really common when we get to things like neuropsychological testing. So when we look at things like processing speed, working memory, other aspects of intellectual functioning, that those things do tend to follow somewhat of a normal curve, and we can use standard scores or percentiles to describe those. But a lot of measures for psychopathology and mental health problems they're not well developed in terms of having these. So we tend to use more of cutoff scores or severity bands. But again, the same idea still applies, where we can compare one person's score to a larger sample and see kind of where they fall. Self-referent comparisons, again, is this idea of idiographic data, the idea of we're looking at one person in kind of individualized score, and we're comparing that person to themselves over time. And so again, that's one of the ways that I talked about progress assessment, is that we can sort of see where someone starts out when they're starting treatment in terms of different types of problems. So for example, thinking about substance use, the number of days drinking alcohol, if they're having alcohol problems or problems related to alcohol, I should say. And we then sort of track their changes over time that are specific to them, their symptoms, their drinking, and potentially different ways that it's impacting their life. And we just compare, their scores over time. So it's a self-referent comparison. So reliability is another key aspect. We started to talk about this a bit in the research methods module. So I'm going to talk about a couple of different aspects of reliability, but kind of go through, briefly some other parts that we've already talked about. So one aspect of reliability that is important for assessment is the idea of test-retest reliability. Is that when we're using different measures, including screening measures or diagnostic interviews that are, where we're reading questions to the client and having them give us answers and we're kind of marking down their answer, we want to see some consistency over time in terms of that person's scores or their ratings or the clinician's ratings for those problems. So this is kind of a key part of reliability in a clinical arena. But one question is that if we're measuring something like depression or anxiety or substance use problems, then we want to be thoughtful. Do we expect change over a certain period of time? So for certain types of concerns, we probably want to have our test-retest period closer together. So if we're tracking depression, we probably want to have it maybe be with the first assessment point and the second assessment point being maybe 1 or 2 weeks apart. We don't want to go much longer than that because we know that depression changes, it can change pretty rapidly, and it's episodic, meaning that there's episodes and it goes kind of up and down over time. For different issues or different things that we might be assessing, maybe our test-retest period can be longer. So for things like personality or neuropsychological functioning, our test-retest period, it's okay if it's longer because we don't expect those things to change as drastically across a longer period of time. Inter-rater reliability, I mentioned this in the last slide set. The idea that we want 2 raters to sort of be rating, something the same way and be rating it consistently. So if we have 2 different clinicians who are theoretically be interviewing the same person, maybe they see one clinician first and then they get a second opinion. We would want those 2 people to come to the same conclusion, make the same inferences about what a person is struggling with. So inter-rater reliability is a form of consistency of measurement or assessment. Internal reliability has a couple of different ways of looking at that. And again, this is really when we're looking at a questionnaire in particular, when we're thinking about a questionnaire like the PHQ-9 or GAD-7. And usually this works better for longer measures when we're thinking about this first type of internal reliability, which is a split half reliability. What that means is that we want to see consistency across the first half and the second half of that questionnaire, that we expect those 2 scores to correlate. So we want some balance across how people are rating, and there are some different ways to kind of get good split half reliability. But again, basically divide the questionnaire up into 2, and you see how highly those are correlated, or again, what that correlation means is a degree of consistency between the two halves of that questionnaire. Another one is what is commonly termed internal reliability, but is coefficient alpha or Cronbach's alpha. And this is just a way of kind of thinking about how well the items on a questionnaire, how well they go together. And what I mean by how well they go together is how highly they correlate. And in general, we want to see pretty high correlations between the items that are on a questionnaire, because what that tells us is that we're getting at the same construct, the same idea, as we're asking different types of questions about that. So if we're asking 9 questions about depression, like we see in the PHQ-9, we want to see each of those questions be pretty highly correlated, because then that would suggest that they're all kind of measuring the same underlying factor or construct, which would be depression. This number is a function of the number of test items and the average inter-item correlation. So that is kind of how scientists look at this number. One key thing to know is that we can inflate alpha really easily by just having more questions, more test items that kind of all sound the same. So that's one way that people could rig the system if they wanted to. We try to minimize that in science, but that's one critique that people have of using this metric. And we have some different kind of cutoffs that we think are useful, 0.7 or 0.8 for different measures. That's not, this number isn't really important for you to know, but it is important for you to know that this is one, coefficient alpha is one form of internal reliability. And it's a metric of the correlation between all the items that are included on a questionnaire or on a scale. So validity, again, as we're kind of talking about that, really the definition of validity is how well does that test or that questionnaire measure what it's designed to measure. So if I'm measuring substance use problems, how well does my measure kind of get at that construct or that idea? And there's a lot of different forms of validity that all go under one broad umbrella term of construct validity. So construct, again, is the thing that we're trying to measure, that depression, that anxiety, academic ability, academic functioning, intellectual function and cognitive ability, as schizophreniform kind of symptoms. So there's lots of different things that we could sort of have as that we're trying to say that's the construct that we're trying to get at. So there are a few different dimensions that I want to mention here on this slideshow. So face validity is one where that's really, really basic. That is basically when you look at the item, does it seem to be measuring what you say it's measuring? So does it seem to be asking about depression if you say it's about depression? So face validity is useful in some cases because we want to be able to kind of tell that it's getting at that construct. It can be problematic if the people who are answering our questionnaire know what we're trying to get at and maybe have some reason to answer in a way that is kind of deceiving. So we sort of want to balance face validity. Sometimes we want to ask questions that maybe have lower face validity because we want to understand whether a person kind of their score on that scale with questions that maybe don't clearly give away what we're trying to test. So that's kind of a tough balance point. There's some kind of balance there that scientists need to have. Usually we try to maximize face validity. Content validity really thinks about this idea of what are all the different parts of the construct that we're trying to measure? What are the different dimensions? And so with something like depression, we're thinking about different dimensions in terms of mood, in terms of motivation, in terms of physical symptoms. And so that relates to things like excessive or lower sleep than usual, and lower or greater appetite than usual, or weight gain or weight loss. So those, the idea of motivation and affect or mood would be different than maybe the physical symptoms. So maybe those would be multiple dimensions. And the idea of measuring stress, that might be another domain that we would be interested in. So content is what sort of aspects of that construct are you measuring? And we want to try to be balanced in terms of getting at all of them. Criterion validity is something that's really interesting because it's, again, we're asking these questions and they're supposed to map onto something that we think is, you know, is real, that we think is how people actually kind of exist in their daily life, and the ways that their different problems affect them. So criterion validity is how well does that measure that we're looking at, how well does it map onto more observable things that a person is experiencing in their daily life. And there's kind of three different ways that this can happen. We can look at it in terms of concurrent criterion validity. So that's criterion validity at the same time. That's predictive. So how well does our measure predict something that happens in the future? And postdictive, which is how well does it predict something that has happened in the past? So I think one good example of this is looking at something like, again, a personality assessment, we might measure something like conscientiousness. So for those of you who are watching the lecture, you know, around when I post it, maybe your schedule just lines up, or maybe you're super high on conscientiousness. You know when the assignments are due, you know kind of how to fit things into your schedule. You're aware, you're thoughtful about all those things, and really aware of again, making sure that you get your assignments done on time. So maybe I have a scale on conscientiousness. I have you know, fill that out. There's different criterion that we may want to look at, or we might think that would be associated with your scores on that scale. So one would just be maybe your grade point average. That could be one. It could be now, it could be from high school or middle school, or we could think about taking your score and predicting your future performance, maybe your overall GPA here at USC or in your undergraduate. So that would be kind of one example of an observable thing that we would want to map onto our questionnaire scores to help with construct validity. Convergent validity is again a part of construct validity. Convergent validity is how well does that measure, that questionnaire, that test, how well does it correlate with other measures that are supposed to measure something similar, or measure something that's, you know, really the same thing. So how well does a PHQ-9 correlate with another depression measure, like the Hamilton Depression Scale? Discriminant validity is something that people often get tripped up on. So discriminant validity, again, is part of construct validity, but basically it is helping us to understand how well or how much someone's or a group of people's scores correlate with other instruments. Again, it's kind of like convergent validity, but here what we're expecting is we're not expecting it to correlate in a negative direction. So again, with measures that, with convergent validity, we would expect for a measure that's measuring conscientiousness, for that to be highly negatively correlated with a measure that's looking at impulsivity. So what I mean by that is that if you score higher on a measure of conscientiousness, then you're probably going to score a lot lower on a measure of impulsivity, because those are related constructs, related kind of measures. And so we would expect those to be correlated, but there it would be in a negative direction. With discriminant validity, we're actually expecting a very small correlation or a zero correlation. So we want to see that the measure doesn't correlate with things that we expect it not to correlate with. So that's another part of construct validity. And then incremental validity is the idea that, again, as we're developing new measures, we want to see that that test is kind of adding additional information above and beyond other measures that are already being administered or already out there. So that's another part of construct validity. I mentioned this again in module 2 for the research methods, but we try to go for measures that are both reliable and valid, because again, we want to see consistency in our measurements, and we want to see that it's accurately mapping onto our target of assessment, that construct that we're trying to understand. So so this is kind of, again, a way of thinking about how we try to balance reliability and validity. We try to have both, and it's really difficult to have validity without reliability. So that's important to think about. And if you're reliable, you know, you're consistently getting the same thing, but you're off, you're not valid, that's still not a good situation to be in. So we want to be in this last kind of quadrant here, where we're both reliable and valid. wanted to say just a couple of things about um, developmental and cultural considerations related to assessments. And I think the book does a really nice job of that. But I just wanted to kind of point out that those are things that we're often thinking about when we're looking at sort of selecting a measure. We want to understand how well that measure has been validated, what the psychometrics are for someone in the group that we're working with. So if we're working with someone from a culturally diverse population, again, that could be in lots of different dimensions: race, ethnicity, disability status, gender identity, sexual orientation. We want to understand, if possible, kind of how the measure, how the test works with that person. A place where we see that there are some differences out there is that there's been studies done showing that some items on questionnaires or some measures perform differently for men and for women, or they perform differently for people of higher or lower education status. So that's a way in which culture really matters in terms of the properties of assessment instruments. We want to try to choose the instruments that are, again, the best fit for our group. And if there's not good scientific evidence out there, we want to be acknowledging that. We want to kind of make sure that we're mentioning that when we're writing up reports or talking with clients about that. So I think that's one of the keys there. When we're designing measures, we want to make sure that they're as culturally appropriate as possible. So that means that we're kind of looking at the language that we're using in the items. We want to test those items broadly across different diverse samples. We want to make sure that questionnaires are, if they're going to be administered to kids, that the language is it can be understood by kids. So maybe we want to have a different measure. If there's already an existing measure for depression, maybe that same language isn't going to apply well to kids, or maybe the symptoms look a little bit different. We'll talk about that when we get to mood disorders and depression, where irritability is a lot more common of a complaint and symptom among kids and adolescents compared to adults. So we would want to make sure that we have an irritability question on our depression measure for kids. And the other thing to kind of mention is that some types of assessments, especially around neuropsychological testing and achievement testing, those have tried to take a more direct approach to to taking culture out of the equation as much as possible. So trying to make sure that if we're looking at someone's mental ability, if we're looking at their cognitive functioning or their intellectual capacity, that we're not biasing it just based off of whether or not they have a lot of exposure to the mainstream culture. So a lot of the IQ tests that are out there, people have criticized because they're maybe more dependent. Some of the subscales or parts of the tests are maybe more dependent on sort of just knowing, for example, American or Western culture. And for people from other cultures, they may not know some of those things. So verbal fluency in particular, kind of information type of subscales, we want to be careful about using those in culturally diverse populations, immigrant populations. So I just wanted to kind of add that on to the chapter. And then I'll talk a bit about ethics and responsibility in a shorter kind of lecture in just a little bit here.